So this is my name, Helena Filipe, and these are the colleagues, the younger colleagues, the residents that I am very proud to bring to me or with me also to this presentation. Let's look at this topic as looking at systemic conditions as causes for ocular surface diseases. And on the other hand, let's look at when we are at the clinic, looking at the eye examination, and by that looking for cues that, or clues that can trigger our reasoning for looking for systemic diseases. Let's start by the first. So there are a lot of systemic conditions that can have implications on ocular the visual system, and these can be a categorization that we can follow. It's a complex complexity, difficult taxonomy that we can follow, but we have to find some that can help us. So this is one of them, and we can categorize immune and inflammatory diseases, endocrine diseases, neurological medications, and other systemic conditions where we can put in this basket a lot of others that don't fit the other categories. So let's start by the autoimmune and inflammatory diseases. There are a lot of them, as you can see. It's impossible to be speaking about all of these. We have some pictures here for illustrating, for instance, the first one at the left, filamentous keratitis with associated with Sjogren's syndrome, with rheumatoid arthritis. We have this ulcer, peripheral ulcer, also illustrated with the lack of substance of cornea, or with the ASOCT. We have also all the manifestations of allergy. We have here the papillae, the supratarsal papillae associated with vernal keratoconjunctivitis, and also with other diseases as multiple sclerosis, grammatolosis, with polyangiitis. We can find keratitis, scleritis, uveitis, for instance, the syndrome, the Cogan syndrome with interstitial keratitis and systemic vasculitis, and all those diseases related with immunobullous diseases with blistering lesions affecting the ocular surface in its many ways, and we have already heard about those this morning in these previous marvelous presentations. Now, the second group would be these endocrine disorders, and we might take a little bit longer looking at the diabetes mellitus. So, diabetes mellitus is a leading cause of blindness, as we know, especially in these range of ages. The corneal complications are often underdiagnosed, but they are very frequently found if we look for them, as you can see. And also diabetic keratopathy is related or associated with epithelial defects, sometimes difficult to heal, delayed wound healing, and increased susceptibility to infections. Diabetic corneal neuropathy is associated with a very important decrease of corneal sensation, and by consequence, or as a consequence of this decrease of corneal sensation, nerve damage. Epithelial abnormalities, we can see that there are alterations in the basement membrane composition and also stem cell dysfunction. Epithelial changes are related with the increase in duration and severity of diabetes mellitus. We can see this correlation, and this also brings a problem that, for instance, this is an example of what happens in the United States of America, that 25% of the corneas for transplantation come from diabetic donors, and we know that these corneas have alterations as we start to describe right now. So wound healing is hindered in diabetic keratopathy. and it's associated with altered growth factors, cytokines, integrin, MP10, an increase in glycation with its end products, and changes in microRNA levels, and also dysfunction corneal stem cells, and also a decrease in keratinocyte density. So there's a lot of differences, a lot of changes that we can find at the level of microscopy and molecular level in the corneas of patients with diabetes mellitus. When we think about the corneal neuropathy, which is a very significant complication of diabetes mellitus, and it's also recognized as an early finding of diabetes mellitus, correlates with disease duration again, and also with severity of diabetes. And what we can find is the decrease in density, and also a decrease in density of the fibers, but on the other hand, an increase of the tortuosity of the fibers that stay there, as we can see in the picture above. So there's a decrease in corneal sensation, which can be kind of the song of the mermaid. It's good because the patient don't feel any pain, but on the other hand, pain can be a very ally to us in making us aware of what's going on. And this is exactly what happens in these kind of patients with diabetic corneal neuropathy, and it's related with the impairment of the subbasal nerve plexus, as we can see in the image also in the slide. So diabetes is a risk factor for dry eye disease as well. There's a significant tear dysfunction. So we can see in these patients a decrease in the Schirmer and also in the tear breakup time. We can see that dry eye disease is more prevalent in diabetes mellitus patients than with the non-diabetic controls. Diabetes mellitus with more than 10 years of existence for the patient, and also a very poor control of this disease, is also associated with high rates of dry eye disease. And also the meibomian gland dysfunction is also prevalent in very significantly registering significantly incidence in diabetes patients. Corneal nerve fiber loss and reduced sensitivity is common in diabetes mellitus, and this also comes associated with reduction of tear secretion. And when we think about dry eye associated with diabetes, I would say, I will generalize for all dry eye disease, but think of this in diabetes as needing a comprehensive approach. And this means sometimes a multidisciplinary team involving very actively the patient as well. So in a kind of an overview, what we can see in corneas of these patients are several differences as we have in this slide. So starting by the cornea, collagen, fibril bundles, abnormal keratinocyte density that is decreased, and by on the counterpart, the rigidity and thickness might be increased. And this is interesting because investigators started to think that, well, what about keratoconus in these patients? This is just an idea. Differences also in the endothelial layer, pleomorphism, polymagatism, reduced cell density in the conjunctiva, decreased goblet cells, for instance, increase in cytokines, and also an abnormal microbiome. All these have importance for the ocular surface health. Tear film, we can also see differences, as we can see. And a word of remark for the severity of diabetic retinopathy associated with the severity of keratoconjunctivitis sicca. We can also see differences in biomechanics. So as we said, a higher thickness and rigidity related with also poor control of diabetes. Could this be some kind of a protection for keratoconus? It's just a question that starts to be glimpsing in literature. Surgical complications are also more frequent with these patients. And there are current treatments, symptomatic more what we have right now, but there are some emerging promising treatments, as you can see here. It's a lot of work. It's all in research, but it's a hope in the future that something will most definitely will appear in the future for tackling directly these patients with these special predisposition for ocular surface disease. The other one is Graves' disease. The Graves' disease, what we can see is the dry eye is very prevalent in these patients, more than 50%, and usually associated with the severity with Graves' disease, again, like with diabetes. Again, we can find some corneal and biomechanical alterations. And the other one is Addison's disease, which is not so common as diabetes or even Graves' disease, but it can also develop with keratoconjunctivitis. And very importantly, there are some reports on limbal stem cell deficiencies leading to vision loss. So there's a component of inflammation that has to be tackled very importantly, and also comes in our side in terms of the ophthalmology alterations. The other one is hyperparathyroidism, which is characterized with this band keratopathy and endothelial polymagatism and pleomorphism, just a word for this disease that can also be present when we see a band keratopathy, and it will be worth to at least approach in our history with the patient if there's any risk factor for this, and can be cured if tackled specifically. And when we think about neurological conditions, a word of remark also for the multiple sclerosis, which can very early manifest with alterations in the suplex layer that can be very at least easily for the ophthalmologist to be demonstrated in these images, as we can see with confocal microscopy. And also a very interesting finding that is the correlation with these alterations of corneal nerve loss and also the severity of cognitive and motor dysfunction for Parkinson's disease. With medications, this is common and it's common knowledge, but sometimes it just can skip in a history at the busy clinical setting. But have this idea is important also with these patients, because it can be mandatory and can be the key to solve the problem before escalating our therapy without addressing this aspect. Other conditions, there are a lot of them, as you can see. Metabolic disorders as Wilson's cystinosis with deposits in the cornea, the vortex keratopathy with Fabry disease, depositions of material with mucopolysaccharidosis, dermatological conditions, in a word of remark for rosacea, and for the infections, just a word for the COVID-19, and this interesting and very recent finding of AC2 and TMPRSS2 in its products that can be a factor, if I can have just 1 minute, can be a factor of more easily penetration of the virus in the cornea and infection, and also a word of caution also for the varicella zoster virus to be addressed very early. For ocular diseases, dry eye disease is associated with very several systemic diseases we have seen. Ophthalmologists can be the first person to diagnose. A word for pain without stain for endocrine diseases and also neurological when there's a very strong component of neuropathic pain, and also for dermatological components, and that can be the key to the successful management, and also the medications, as we saw before. Differences in Asia, dry eye diseases in Sjogren is more associated or less associated with other diseases with seronegative. It's more prevalently more seronegative as opposed with Europe. And I think I cannot say more about diseases and systemic diseases. Just as a finalization and as a key message is to be aware that when, as ophthalmologists, sometimes we have in our hands the first diagnosis of a systemic disease that should be tackled if we wish to be successful in managing the ophthalmologic situation. And on the other hand, we can also be contacted by our colleagues to have our judgment in terms of how we can also help in terms of the ocular manifestations of systemic diseases. Thank you so much.
Thank you so much, Aileen. Thank you so much. Now I am going to move the mic to Professor Singwan and Professor Shiti to highlight some points, and then we can have some questions in 5 minutes before we move to the next session.
Good morning, and these morning talks covered a wide range of topics and laid a very good background for talking about more disease and surgeries. I think the ocular surface, the way I look at it, is like more of a unit, as a functional unit consisting of 3 elements: the preocular tear film, the epithelia, and the surface sensitivity. So we should look at as a whole unit rather than in the components. I'll have Rohit to make his comments.
I thoroughly enjoyed all the talks today, and started off with Dr. Safa, Dr. Evren, and Dr. Mohammed. One of the key points in all of you we brought in, very interesting, is the role of microbiomes. We know that only with all the latest technologies, we can only culture only 10 to 12% of bacteria. Others are not culturable. That links what Dr. Manisha Acharya's talk about many patients with the vague fungal or corneal ulcers. You pick up the commensals, you pick up something which is already known, but there are 90% of them which is not picked up by any of your cultural methods. That's something which is very interesting here. And also about the Dr. Sandra about the lifestyle changes. One thing I want to add is, which we've been working extensively in the last 6 months, is the role of cosmetics. People, and we look at cosmetics and changes of the biomarkers. And what is very interesting here is, when you use any cosmetics, whichever brand you use, it changes the whole dimension of ocular surface for that constant time. And constant use of cosmetics for a long time would impact it. So that means many times we may do a surface ablation or a PRK or a cross-linking. And if you have not checked the usage of cosmetics, at least we need 3 days washout time, because it increases TNF-alpha, which is one of the major drivers of haze. So that is one thing very important. And of course, very interesting lecture by Dr. Helena about all aspect of what changes. And one important point is the role of diabetes and whether it is a protectant against keratoconus. But we do see a lot of insulin-dependent diabetic patients, young people coming to with keratoconus. So that's again something which is debatable, because a lot of the O2 radicals which is there, which creates a cross-linking effect, is known to create a natural cross-link in diabetic, which we don't see in people with children with insulin resistance diabetic retinopathy. That's something which is important. And the last thing from my side for the talk, because it was more of endocrinal diseases, I do check a lot of my patients for fasting insulin resistance. Fasting insulin resistance is becoming one of the major reasons why many drugs don't work, because many of the fasting insulin resistance patients do have very poor receptors because of the damage, especially the dopamine, the insulin, and all these receptors are knocked off on the ocular surface, which are necessary for hemostasis and maintaining. So that is also one of the things which I thought we'll mention in the diabetic retinopathy.
Thank you so much. And any questions before we move to the next after the basic? Because I think basic is the most important to understand how to diagnose and manage in the rest of this interesting day. Okay, so I think next, move to the next session. I will ask Ozleen. She's going to moderate the next session with Dr. Hani Sakla, Dr. Safa, and Dr. Oksana. Please, can we come to the stage?
Change it here.